everyone, Shanna here with Karen. We're going to be going over another question out of our 10 questions that we have listed on our website. You will see the question below. Today I'm going to have Karen read the question to me. We'll display the answers for you, so it gives you some time to pick which one you feel is right, and then we'll discuss that. So you ready, Karen?
I'm ready, Shanna.
Right, great.
Good to see you today.
Yes, good to see you too.
Okay, this is question number 1. A patient with an unsecured, which means not repaired, subarachnoid hemorrhage requires close monitoring to minimize rebleeding. The following modalities are used to prevent rebleeding. And so now you have 4 choices. So if you want to go over your 4 choices, and you can pause the video and decide what your choice is. Okay?
That's great. So pause now and then pick out your answer, and now we'll go forward.
Okay, so the correct answer is B. And so, Shanna, can you tell us a little why that is the correct answer? Number B.
So answer B, Betalol infusion with a target MAP of less than 110 or a systolic blood pressure less than 180. And then we're going to give normal saline to prevent hypovolemia. First off, I'm going to start actually with why the other ones aren't correct. I think that might be easier. So in A, it talks about basically a Nitrate infusion. I know some people might get hung up on this because they might think like, okay, well, Nitrate does bring down blood pressure. But one of the big things with Nitrate is that it does affect our cerebral perfusion pressure, and it's very potent. So anyone who's worked with Nitrate knows like a small change can drastically drop pressure really, really quickly. And the problem with that is like if our pressures go down really quickly, you know, our cerebral arteries are going to want to open really fast, right? Because they're like, oh no, we got to perfuse the brain. And so that can send an ICP from a normal range to an incredibly high one. So the risk of having that variation of like, it goes up and down too easily, keeps us typically from using Nitrate. On C, we talked about Nicardipine. This is actually the drug that we see the most being used as a calcium channel blocker. And I know a couple nurses who I went over this question with at work, they weren't really sure about like, oh, well, we use Nicardipine drip. Why would Betalol be the correct answer? Well, in this one, it says Nicardipine PO. And we all know if you want to have better control, we don't give PO medications, right? Because we don't have that tight control like with an IV. So especially someone coming in and we're like, oh, we want to keep a blood pressure in a certain range or keep a MAP at a certain range, we want to have the control. So right away, knowing that C, where it says Nicardipine PO, would not be correct, because in any acute event, especially in a situation like this, where the patient actually hasn't had any intervention, and we're basically trying to keep them from rebleeding. So control is extremely important in this circumstance. And then for D, Mannitol, we're not really concerned with someone, Mannitol isn't used for CPP as it is for intracranial pressure. So this is not the medication used for subarachnoid hemorrhage. That would be used for someone with possibly traumatic brain injury where there's swelling. So B being the answer, Betalol, just like Nicardipine, even though it's a beta blocker, it's fast acting for us, but it doesn't affect that cerebral perfusion pressure and drop it drastically. So the chances of an ICP having to go up and down so drastically, causing, you know, where there's a chance of having some sort of cerebral ischemia, is a lot less likely. If we go into the second part of those answers, it talks about the IV fluids. The main thing with these type of patients, hypovolemia, is like what our goal is. And most people know that, you know, D5W is a hypotonic solution. Now, I've had people say, oh, well, actually, it's an isotonic solution, but then there's that transition in the body where it becomes, you know, hypotonic. Okay, so whatever that is, just know that we're not giving D5W, because in the end, it is a hypotonic, and it's going to take that fluid and draw it into the cell and then increase swelling, which is extremely bad. In fact, with these patients, we go the opposite way. If we're not using an isotonic, we could use a hypertonic, which we are doing our best to keep that fluid out of the cells. So that's an important point, because I have seen questions around this topic about D5W and using hypotonic solutions on any kind of brain injury, subarachnoid hemorrhages, intraventricular hemorrhages, stuff like that. I think that's the gist of it. What do you think, Karen?
You know, it's so funny that you talk about that hypotonic D5W, because when it's in the bag, it's hypertonic. But as soon as it goes into the body and the body uses that glucose, then you've got water.
Perfect. Yeah. So you said it better.
Water. And so that's going to go and just really swell those brain tissues. So that's kind of a no-no, right?
Yeah, that's definitely a no-no. But it's funny is because a learning pearl for myself was that being that dextrose made it a hypertonic solution, because at first I was like, how is that? You know, so it was something for me to learn too. But you're right. What matters most is what happens to it once it's in the body.
Right. It doesn't matter too much when it's in the bag, but what's the consequence? So that's excellent, Shannon. Well, thank you.
Yes.
That's a great review of question number 1.
All right, sounds good. Please look out for our other videos. We're going through the 10 questions that we have posted on our website. Also know that you can subscribe to our channel, and then you could automatically have these questions, or these kind of like Q&As that Karen and I do, automatically sent to your inbox. So please subscribe. Thanks so much for watching.
Thanks.
Bye.
Bye-bye.